Hi, everybody. I'm Dr. Cara Wallace, and I am a social worker, but faculty here at St. Louis University's School of Nursing. And I am here to talk to you all about defining hospice and palliative care today. So let's get started. Just our quick disclosure for the Geriatric Workforce Enhancement Program. And our objectives for today, which are to differentiate between hospice and palliative care, to illustrate key concepts and services of hospice care, and then to examine the benefits of timely end-of-life care. I'd like to start a little bit with some context and background for this talk, which is that we're living in an aging society. There are nearly 60 million adults in the US aged 65 and older, and it's a population that continues to increase rapidly. By 2050, projections indicate that that number will be more like 82 million. If we think about the most common ways that older adults die in the US, those include things like heart disease, cancer, respiratory disease, strokes, Alzheimer's disease. And I think it's important to consider what death looks like for people within those different types of chronic illnesses. So I've included here at the bottom of the slide some different trajectories towards death. And the black line there shows cancer, which typically is a pretty predictable path towards death. People get cancer, they receive lots of treatment. There comes a time when those treatments are no longer kind of able to address the disease itself, and they might transition then to receiving only palliative or hospice care, and they can decline fairly quickly towards death. If you look at the red and the blue line, those represent more of death by organ failure or frailty or other types of chronic illnesses, right? Which is where people are kind of doing okay, and then something happens and they decline very rapidly, but then they can rehab or receive treatment and can kind of bounce back and do better. So it's this kind of up and down trajectory towards death. And kind of with dementia or Alzheimer's or frailty, there can be a much longer, just slow decline towards death. And it becomes very difficult to pinpoint how close someone is to the end of their life. So without this kind of predictable terminal period towards death, this idea of timely access to end-of-life care is unlikely and really challenging and difficult. One concept that describes this is Bernklug's discussion of the ambiguous dying syndrome, which is the reality that many people living with chronic illness are not considered dying until they are on final days, if dying is recognized at all. So this is one barrier that's among many, right, that prevents people from accessing hospice and palliative care during the time when it most could benefit them. But the effects of ththese barriers to care are devastating, as many people die in pain with little control over their surroundings. And those who do make it to a service like hospice care are often only there for a few days. 1 in every 3 hospice patients dies within a week, and 50% of hospice patients die within about 17 days. As healthcare professionals, part of our job is to help educate patients and families about their care options. And in order to do that, I think we have to have a really good understanding of the differences between types of care and options for care, and how to best introduce them to patients and families. And that's what I'm hoping to share with you a bit about today. So this is a really nice visual representation that can help healthcare professionals understand the differences between what hospice care is and what palliative care is. I like to think of palliative care as the umbrella and hospice care as underneath that umbrella. So what I mean by that is that all hospice care is palliative. However, not all palliative care is hospice. And there are a lot of similarities between them, and we're going to kind of go through the definitions for each, and you'll see that there are a lot of similarities, but there are also some key differences. And I think that this visual helps us consider those differences. So if you look here at underneath this kind of crooked line, let's see if my cursor will get over here and help us. We have this line here that shows all of this down here is palliative care. It focuses on this idea of symptom management and quality of life, and kind of palliating the symptoms that are there because of a disease process. And then above this line is this idea of curative care or life prolonging care. And it's really focused on treatments that are treating the disease, right? So that's the role of the oncologist or the heart disease, specialist and cardiologist. Their job is to focus on the disease, while palliative care's job is to focus on the symptoms that are there because of the disease and how we can focus on quality of life. Um, and you can see there's this line down here between when curative care is present, again, treating the disease. And what differentiates hospice from palliative care is that hospice is focused solely on that palliative care and is not alongside curative care. So one of the criteria, which we'll look at here in a minute for hospice care, is that people have to forgo active treatment, a phase of active treatment or curative care. And the focus of hospice care is really dialed in on looking at that symptom management. And again, palliative care can start way over here, getting my cursor again at diagnosis. So palliative care can start and serve someone at any time during their serious illness and is not at all tied to terminality or death. In fact, people can be eligible for palliative care without terminality ever even being a factor, right? Someone can be in a serious car accident and need some pain and symptom management that palliative care could provide, and then they can get better and no longer need palliative care. So it's not at all tied to this idea of terminality, and that's one key difference that's often misunderstood. So let's look at the actual definition for palliative care. And this is from this CAPC's definition. So again, it's a focus on people living with serious illness and focus on relieving symptoms and stress surrounding serious illness, regardless of the diagnosis. It focuses on quality of life, not just for the patient, but also for the family. And one of the key, I think, features of both palliative care and hospice is this idea of the entire team, the entire interprofessional team that works with the patient's other doctors to provide an additional layer of support. So they're really working alongside whatever other team of professionals that are working with a patient and family. It's for any age and any stage in a serious illness. And again, it's alongside curative care and can start as early as diagnosis. And palliative care has really experienced extreme growth over the last 25 to 30 years. Most hospitals now have access to palliative care. And now that we've also seen a lot of growth in outpatient palliative care clinics and in community settings. Ideally, again, these are staffed by full interprofessional teams, though that's in practice not always the case, especially in more rural areas or in newer programs. But ideally, that's how palliative care is best served, is with access to the entire interprofessional team. So some key ideas if we're thinking about how to introduce palliative care to patients and families. They can really get lost if we're trying to introduce it as it's not hospice care, right? Probably not relevant when you're introducing it to patients and families. What you really want to focus on is you can access it along other types of care. Palliative care can help someone live well with a serious illness, helps people with serious illness stay at home rather than having to go to the ER or into the hospital. It reduces physical discomfort, improves quality of life, and makes living with a serious illness easier, both for the person and those who live with them. So again, focusing on this is for any stage of serious illness, and really highlighting the team that comes along with palliative care that works alongside their other care professionals. I think that's, people often complain about the fragmented care, and palliative care, the purpose is to really work alongside those providers and to communicate well with those providers and to bridge those gaps in services. So then let's shift a little bit into thinking about what hospice care is. Again, I'm going to kind of start with this idea of definition, and this key difference between hospice care from palliative care is this idea that active treatment is no longer a part of the plan of care when hospice care is involved. And that's one of the Medicare guidelines for hospice care. A person has to give up that active treatment phase and focus primarily on the quality and palliative care stage. Part of hospice philosophy is that dying is a normal process of living, and it's about helping people live well through the remainder of their life and really focus on treating the symptoms that are there because of the disease process, not treating the disease itself. The two main criteria that make someone eligible for hospice care is that there's a certificate of terminality, which means that a physician has looked at a patient and said, it's this question of, I wouldn't be surprised if 6 months from now this person was no longer living. That doesn't mean that the patient dies within 6 months. And there are lots of hospice patients who have lived much longer than that. And there's a process for being able to recertify them for ongoing hospice care. Someone never loses their benefit of hospice care once you are on it. You can be on it as long as you are continuing to be eligible for hospice. If you come off of hospice care, again, you never lose your hospice benefit. You can come back to it when your condition necessitates or you become appropriate again under these criteria. And again, after the certificate of terminality, which we've talked about several times, is this idea of not seeking curative or life-prolonging treatment. However, when we think about how to introduce this to patients and families, starting with that definition and eligibility criteria can be really overwhelming. So it's not really where you should start. I was a hospice social worker and a hospital social worker for many years. And one of the things that I had the benefit of doing is being the person who came into the room to introduce hospice care to patients and families who were considering it or who were considered appropriate for it. And one of the things that I learned was that the best approach to this is meeting people where they are. I often started with questions about their values and their hopes for their care. And then as appropriate, I was able to talk about how hospice could help meet those values and needs that they were having. And really then, in other words, to talk about how hospice aligned with those hopes and values. And to introduce to them all of the different services that hospice could provide. I learned that I could have a whole conversation about hospice care and never mention death once. Because one of the things that I learned as a hospice social worker was that hospice was not always about death. It was really about helping people live well with whatever time they had left for the remainder of their life, of which death is a part. So here's just a list of some of those services, key concepts and services that hospice provides. Again, focusing on quality and addressing the symptoms that most bother the patient, serving the family as much as it does the patient themselves, access to the entire interprofessional team, that there's a physician and a nurse and a social worker and a chaplain and hospice aides that can come in and help with hygiene and showering. There's often volunteers, sometimes even massage therapists or music therapy can come into the house. All of these different kinds of services are available. And I would share that hospice is covered by insurance and that all of the medications that are related to their hospice diagnosis or that are related to their comfort and care are covered and actually are delivered there to the home. And that hospice comes with supplies like if they need gloves or bed pads or wipes, and all of those kinds of things could be provided by hospice, along with a bedside commode or a hospital bed or a special mattress that can help make sure that the patient's not laying in the same spot all of the time with some air pressure. A wheelchair, a walker, all of these equipment is a part of what hospice provides as normal care as needed within the home. It's also a matter of being able to receive the care in the place that you call home, no longer having to go in and out of the doctor's office or in and out of the hospital. Hospice can help make the most of precious time and help people enjoy more moments of life. And the hospice team will be there whenever people need them. So there's this 24/7 availability, right? There's a phone number that people can call any time of the day, and hospice staff is on the other line of that call. And there's always a nurse and social worker or chaplain on call that can come out to the home even in the middle of the night if there's a crisis or just questions about symptoms that are going on. Finally, I want to talk a little bit about the benefits of this type of care. When I was a doctoral student, I was doing research about the timing of hospice care. And I had a committee member that asked me, but why would anyone ever want to be on hospice longer, right? Or this idea of why would anybody choose this type of care? But the answer for why someone would choose hospice or palliative care is actually really simple, because research has shown over and over again that hospice and palliative care improve symptom management, they improve quality of life, they improve quality of the dying experience for the patient and for the family, and also that after a patient dies, the bereavement is less difficult when hospice care has been provided there in the home. So hospice and palliative care overall improve end of life quality, better quality of death, better symptom management, and less difficult bereavement. Beyond that, there are these huge Medicare studies that have been done with where they've matched patients by race, gender, diagnosis, age, and hospice patients and non-hospice patients, and they've matched them by all of these different factors. And which group do you think actually lives longer? It's the hospice patients. They live longer, and the overall cost of services is less. Not to mention the better quality that we talked about on the former slide. So I'd like to end with this. I did some research several years ago where I asked people what they first thought of when hospice was introduced to them. And overwhelmingly, and I think this is true just for the general public as well, overwhelmingly, people, when you think about hospice, you automatically think about death. But then I asked a group of people who had been in hospice care what hospice meant to them now that they were experiencing their services. Their responses were completely transformed. Instead of death, they told me that hospice was about support, comfort, loving and caring staff. The experience of hospice care changed what that care meant to them. And I think that's part of our job as healthcare professionals, is to help reframe what hospice and palliative care might mean to people when they first hear about it, and to teach them about the benefits and to clearly be able to answer their questions and differentiate between them, but also introduce them in a way that's easily understood at the time that they're considering those services and as appropriate within the context of their care, right? So not necessarily getting bogged down by the definitions, but really focusing on what the service can provide them and how it can best benefit them. And being knowledgeable ourselves about those differences so that we can answer those questions as patients and families have them. I'm always available should you have questions and would love to hear from you. Thanks so much.